He's not breathing. His respiratory rate is 8, and he's setting 84%. He does have small pupils and decreased bowel sounds. He gets ventilated by bag valve mask for a few minutes, gets a very tiny amount of naloxone, and his respiratory rate picks up, his SAT picks up, and he doesn't become hypoxic again. 2 hours later, he is awake. He said he just got out of jail that morning, and he used a bundle of heroin and since he got out. Anyone know what a bundle is? It's 10 bags. So that's a fair amount. So this is a really common scenario, right? So when people chronically abuse a substance, they get tolerance to that substance. And even though when we know that you can get anything in jail that you can get on the street, probably not the same levels that you'd be able to get if you were free. And so people lose their tolerance when they're in a situation where they can't get access, whether they're hospitalized or they get incarcerated. And then when they get out, they may use the dose that they used to use before, and that's a really vulnerable time for these patients. It's a really common time to overdose. So this is the opioid toxidrome. And you notice I use the word opioid and not opiate because there's only 2 natural opiates. The morphine and codeine are derivatives of the opium poppy. And in places like Afghanistan, the poppy produces these pods, and it's scored with a metal comb, and this resin is collected. And the resin is opium. If you refine the opium, there's morphine and codeine in there, so those are the natural opiates. Then there's some small structural modifications of morphine and codeine that give us our semi-synthetics. So heroin is diacetylmorphine, hydromorphone is our Dilaudid, oxycodone is Percocet or Tylox or Oxycontin, hydrocodones and Vicodin. So these are all structurally very similar to morphine and codeine with small changes. And so they all show up on urine tox screen because they're structurally similar to morphine and codeine, which is what we test for when we do a urine tox screen. And we have our pure synthetics. So meperidine is Demerol. Profoxyphen was in Darvon and Darvocet. It's now off the market, but there may still be some of it out there. Fentanyl, methadone, these are all structurally very not similar to morphine and codeine, but they bind to opioid receptors. But because they're structurally so different, they tend to be missed by urine tox screens. So again, urine tox screen is not really that useful. It's more important to recognize your toxidrome than to rely on a urine tox screen because it's going to miss some critical ones. In New York, where we have more methadone maintenance patients than the rest of the country combined, it's so common that people are on methadone that we specifically test for it. So you don't have to ask for a methadone test. If you do a urine tox screen, they test for opioids and they test for methadone because they know the methadone won't show up. And there's so many people on methadone. So there's a lot of different types of opioid receptors. The most important ones are going to be your mu opioid receptors. That's where a lot of the analgesia comes from, but it's also where the euphoria that leads to the dependence. Some of the other effects that we look for, the kappa opioid is where the meiosis comes from, and the sigma opioid receptor is no longer considered an opioid receptor, so it's not on here. So the opioid toxidrome is sedation, respiratory depression, and GI dysmotility, as well as meiosis. Meiosis is not 100%. If you have some of the synthetics, they may not reliably cause meiosis. Also the situation of a speedball, which you guys know what that is?
Cocaine, heroin?
Yeah, heroin and cocaine mixed together in the same syringe and injected. So it depends on when you see them. If you see them early, the cocaine tends to predominate. If you see them later, they tend to look more opioid. So early on, their pupils may not be small. And then finally, if they have anoxic brain injury because they were not breathing for too long, then they may not reliably have small pupils. So in terms of managing these patients, if they're breathing normally, then treat it like a sedative hypnotic toxidrome. Just leave them alone, it's going to wear off. There's nothing really to do for them. It doesn't matter if they're unconscious, right? We've learned that lesson from the sedative hypnotic patients. So if they're breathing, leave them alone, it's okay. If they're not breathing, then ventilate them, right? So this is a common rookie mistake that I'll see is somebody comes in, they have a respiratory rate that's really low and they're satting low, and someone puts them on some supplemental oxygen and their sat goes up and another life saved and walked away. But the problem is they're still not breathing. You could have a very low respiratory rate and your sat may be okay if you're on 100% non-breather, but you haven't fixed the problem that they're not breathing. And so they get more and more respiratory acidosis and hypercapnia, and you haven't fixed that by giving them supplemental oxygen. So you want to ventilate the patient who's not ventilating, and then you can think of our antidotes, naloxone. And naloxone is a competitive opioid antagonist. And it's really only indicated in patients who are hypoventilating. This is from a pre-hospital study, but this is Jerry Hoffman, not Bob Hoffman at New York City Poison Center. So it's really the only people who respond to naloxone are people who are hypoventilating. And so if you ask what the dose is, if you ask a paramedic, they might say 2 mg because that's the most that they can give in the field. If you ask a nurse, they might say 0.4 mg because that's how much comes in the vial. But really the right dose of naloxone is the amount to make someone breathe. So in New York, where we have so many methadone maintenance patients and they're really sensitive to naloxone, we like to give very small doses and titrate up because sometimes those methadone maintenance patients will take something else, right? So you have a methadone maintenance patient who took Xanax today, and they come in, and if you're really aggressive with that naloxone and give them a big dose, they may be withdrawing from their methadone but still unconscious from their Xanax that they took today. And so kind of unconscious and vomiting is a pretty bad combination. So better to take a small dose and titrate it up. You can take your 0.4 mg vial and dilute it into 10 mLs and just gradually give it. You can always ventilate them by bag valve mask until you get them to where you want them. And so you titrate it to effect. If you get them breathing adequately and they start to hypoventilate, then you can start an infusion. So a typical dose of naloxone is geared towards a dose of heroin. So naloxone lasts 30 to 60 minutes. Heroin lasts maybe 4 hours, kind of similar to morphine. So if somebody takes a heroin overdose, by the time someone recognizes it, calls the ambulance picks them up, brings them to the hospital, you evaluate them, order their naloxone, nurse gets it from the Pyxis, they get the dose. By the time that additional hour of the naloxone wearing off, you're probably past the peak effect of the heroin, and it's unlikely that they're going to start to hypoventilate again. But somebody takes an overdose of methadone or OxyContin, or they're a body packer and they have a leaking bag of heroin in their GI tract, then that 60 minutes, 30 to 60 minutes of naloxone is probably not going to be enough, so they may need to be on an infusion. So 2/3 of whatever work to wake them up is the right amount to give per hour. Some complications of opioids. You had a question?
The thing I always confuse me, the 2/3 of the effective dose is when you're giving multiple doses. Is it the total dose that you've given until
the
they
total
start
dose,
to breathe?
yeah.
Or is it the, I've given, 0.04 and then I gave afterwards 0.08 and then that one's,
So no, in that case it would be 1.2. So you give, so you would be 0.1 per hour in that third. Yeah.
How do you change the naloxone dose if you nebulize it? Or is it the same?
So there's a lot of people are into nebulizing naloxone. I personally am against it. And the reason why is the person who needs it most gets the least. And the person who needs it the least gets the most. So it's a very counterintuitive way of dosing something. And you're likely to precipitate withdrawal because the person who's going to keep waking up and getting more and more of the drug. I like to control it by giving it intravenously.
If you can't get a line emergently,
You can give it IM too. Yeah. Joel?
Yeah. What's nice about Narcan is it's absorbed so many ways. And IM works great, sub-Q works great, sublingually works great, and stuff. So if you can't get a line, give it IM. By the time you're getting ready to intubate, and they wake up on the way.
Yeah. There's intranasal now. That's available in the community. So there's a lot of different routes that you can do it.
is the bioavailability indifferent for IM?
No, I think it's pretty quickly absorbed IM.
Yeah, unless they're in deep shock, it's absorbed very well IM, and maybe the difference between that and IV is a minute or two. I've had great success with the IM.
All right, so some other complications of opioids include opioid-induced acute lung injury. And this is most often precipitated by really big doses of naloxone. When people take opioids, they make you hypoventilate by making your brain tolerate high levels of CO2. And if you abruptly reverse that without ventilating them by bag valve map first to get their CO2 down, you abruptly reverse it, the brain wakes up, it's like, oh my God, there's a lot of CO2 around. And it releases catecholamines, and the catecholamines make the vascular bed in your lungs more permeable and leaky, and so you start to get fluid leaking into your lungs. At the same time, people tend to do something called a Muller maneuver as they wake up. Inspiration against the closed bodies. As they do that, that creates hydrostatic forces that pulls fluid into the lungs also. So those two things together really classic for a patient who gets a big dose of naloxone to wind up going into pulmonary edema. But that said, it can happen just from the opioids alone. It was actually first described by Osler before naloxone existed. Finally, anoxic brain injury. So if somebody's just not breathing for too long, they can get bilateral basal ganglia infarcts. This isn't specific for opioids. You can see this with methanol. You can see it with carbon monoxide. But kind of classic opioid finding for on HCT with somebody who's been anoxic for too long. All right, we have a few minutes. Let's see if you can identify these cases.
Quick question, Dr.
Yeah.
Just for our methadone patients that come in, do you recommend not giving them oxygen then? And like, is there a little hypoxic or hypoventilating? Is it better just not?
I wouldn't leave someone hypoxic, but I would try to ventilate them. You know, you're going to want to give them naloxone.
Right.
I'd start by giving them some oxygen. I'd get the bag valve mask while the nurse is getting the naloxone and just ventilate them for a couple minutes. And by the time you get the naloxone, you've hopefully gotten their CO2 down to a level that you're less likely to see that pulmonary edema.
But for those guys that end up in the pod, not necessarily CCT, and they're just kind of like hanging around and they're not breathing out, they're, you know, they're arousable, but they're hypoxic. I mean, I just wonder if we're just kind of putting a band-aid on the problem then, they really need to be in CCT.
If they're hypoventilating, then they probably should be in CCT. I think that's a fair rule of thumb for almost any disease stage. All right, so let's, we have a couple minutes. Let's see if you can identify these. 85-year-old woman transferred from the nursing home for bradycardia. She's nauseous and she's a little dizzy. She's got a history of Alzheimer's, GERD, and incontinence, no cardiac risk factors, and the nursing home information is lost in the transition from CCT to POD. And this is her physical exam. I'm not going to read it. I'm just going to let you read it. Tell me when to go ahead. I'm hearing cholinergic.
EKG.
EKG. Some sinus braiding maybe. So, someone said cholinergic, what should we do?
Alright, give a little atropine, give a little bit of bradycardia.
Okay, good. So she had taken Aricept, a cholinesterase inhibitor that's for Alzheimer's. It's supposed to mostly work in the brain, but sometimes you can see peripheral effect. She got to atropine, her heart rate picked up. I've actually seen this case a couple times. It's pretty interesting how often that Aricept tends to cause bradycardia. All right, next. Joel. 8 patients presented to the ED with acute onset of agitation and hallucinations approximately an hour after snorting heroin. They got treated with IV naloxone in the field and just became more agitated and delirious. They were a little hypertensive and tachycardic. They had big pupils. Keep in mind they had just gotten naloxone. Skin and mucous membranes are dry, bowel sounds are diminished, and 5 out of 8 had urinary retention. They all got a full workup. They got some benzos, and over the next 12 to 24 hours, they all got better. And they all say they either used point-on-point or Sting brands of heroin. So what do you think happened? Okay, it's anticholinergic, but they used heroin. Heroin's not anticholinergic. Okay, so it got adulterated, right? And so what could you do if you knew what these patients had? Physostigmine, good. So in this case, the specimens of Sting heroin were able to be obtained and got analyzed in the New York City DOH lab, which those of you who have been to Consultants Conference at the Boyden Center, it's upstairs in that building. And they found to contain heroin and scopolamine. It's the antimuscarinic that's in Jimson weed that we talked about earlier. And they issued an alert to New York City emergency departments, and actually over the next few months, there were over 300 patients like that. It was an epidemic in New York City in the 80s. And once people knew what was going on, they got treated with Pfizer. Joel, you had some of those, right?
Yeah, so, and up in the South Bronx, they were calling it Marco Polo. They gave it a name, I don't know why they called it Marco Polo, but they gave it scopolamine and the heroin. When we first saw several of these cases, everybody was afraid to give them physostigmine, but they were so, once they got the Narcan, which they all had gotten from EMS, they were so classical anticholinergic, but their EKGs and showing QRS widening, and I finally, gave it, and it worked well. But everybody was just so afraid, and I got yelled at and everything. It really worked well.
All right, one last case. I remember this from my first year of fellowship. A 30-year-old man is found absconded in the lobby of a building with $2,500 in cash and the keys to an infinity. And he gets the coma cocktail, and he got agitated and puked, but he didn't really, his mental status didn't improve. This is his physical exam. I'll just let you read that. Let me know when to go ahead. You ready?
Yeah.
All right. So he's slightly Brady. He goes to head CT. While he's in CAT scan, he transiently gets more alert and gives his name. By the time he gets back to the department from CAT scan, it's about 2 hours after he got to the hospital. He abruptly sits up and he's wide awake. All right, good. So he's GHB. He also happened to be on methadone maintenance. So he got that naloxone and started to withdraw, but he was still unconscious from the GHB. A little clue is that a young, muscular guy, GHB initially gained popularity among the bodybuilding community before it got popular as a club drug. All right, any questions? Yeah?
Sedatives, what is the determination between whether you intubate and if two patients have normal vital signs? What's the difference in intubating and not intubating?
So if they have normal vital signs and they're protecting their airway, I would leave them alone and not intubate them. It's the patient who's starting to hypoventilate, which you can definitely see with AHP, which you can see with propofol, which you can see if somebody takes a benzo and alcohol. Those patients should be intubated. You're probably not going to want to give a reversive agent, which there exists for benzos, right? We have flumazenil, but somebody who just comes in after overdosing, it's not really safe to give that to that patient because you don't know if they're dependent and you can make them withdraw in seize. And unlike withdrawal from an opioid, withdrawal from sedative hypnotic is really life-threatening. So the only times I really use flumazenil is when I want to wake someone up that I gave the benzo to, like from the procedural station or something. But you don't want to give that to somebody who's just coming in from the field. So you're just supportive care. If they are hypoventilating, just like you would with another patient who's hypoventilating, then you want to intubate them. Otherwise, leave them alone. All right, thank you.